Hello, let's talk about Cushing syndrome. Cushing syndrome is simply an excess of cortisol in the blood, and cortisol is the prototypical glucocorticoid. Now, a glucocorticoid is a signaling hormone that works to raise blood sugar. That's where the gluco comes from. And corti refers to the fact that these hormones, glucocorticoids, are made in the adrenal cortex, not the medulla. And then oid just means that it's a steroid, which is a sterol, which is a four-ringed signaling lipid with some ketones attached to it. That's what the oid means. And cortisol is produced in the zona fasciculata of the cortex of the adrenal glands, and it is produced in response to adrenocorticotropic hormone, which is released into the bloodstream by the anterior pituitary, and it does so whenever the hypothalamus releases CRH, corticotropin releasing hormone. Now, cortisol is going to primarily work to raise blood sugar, but it's also got a slight vasoconstricting effect because it will synergize with adrenergic receptors, get those upregulated on the surface of cells, causing some vasoconstriction. And it's also got some nuclear effects wherein it inhibits the inflammatory response by suppressing the expression of nuclear factor kappa beta and genes downstream from that. So cortisol, another name for cortisol is hydrocortisone, and cousins of hydrocortisone are prednisolone and dexamethasone. And you've seen these drugs before. You understand we use them to treat inflammatory conditions. So the Wikipedia page for hydrocortisone, that's just cortisol when we give it as a medication. We can use it to treat adrenocortical insufficiency, which is going to be basically a total lack of cortisol in the blood, because if they're made in the adrenal cortex and you've got insufficient activity within your adrenal cortex, you're not making cortisol. So that's a bad thing. So we would just give those patients steroids exogenously. We can also use it to treat high blood calcium, because steroids are going to inhibit vitamin D hydroxylase activity within the kidneys, and so there's going to be less calcium absorption downstream from that. We can use steroids, glucocorticoids, to treat thyroiditis. That means you've got too much free thyroid hormone in the blood, leading to a hypermetabolic state, and hydrocortisone will kind of cool that down. We can treat rheumatoid arthritis with glucocorticoids because of the anti-inflammatory effects. Dermatitis as well, because it's going to stop cells from proliferating. It's going to put your body in a catabolic state. And so obviously you need anabolism. You need to build up proteins in order to divide and multiply cells, and skin cells very frequently. Those are probably the most divisive cells in the body. And so skin cell proliferation is going to be inhibited when there's a lot of glucocorticoids in the blood. Asthma and COPD, well, steroids are anti-inflammatories and they are bronchodilators as well. So those are some of the uses for this glucocorticoid cortisol. It's something, again, that's naturally produced by the body, and you don't want too much or too little of it. Let's get to this SDL. So Cushing syndrome, again, means you have too much cortisol in the blood, and the primary cause of that is going to be a patient that's taking exogenous glucocorticoids. So prednisone, dexamethasone, the examples we just saw. It's called Cushing syndrome anytime you have high blood cortisol concentrations, but it's called Cushing disease whenever you have a pituitary tumor, primarily an adrenocorticotropic hormone secreting tumor. So exogenous glucocorticoids are the bulk of Cushing syndrome, and patients would be on steroids for a very long time. For example, if they just had an organ transplantation performed, they might have to be on steroids for months, years afterwards, or maybe a chronic autoimmune pathology such as lupus or rheumatoid arthritis. You would start those patients on steroids for a very long time to control the inflammation and the symptoms associated therein. Now, diagnosing Cushing syndrome, the first thing you're going to do is check to see if the patient's on any steroids, but if they're not, then there's really three different causes that you're going to have on your differential after steroids are ruled out. And that's going to be Cushing's due to a problem in the pituitary gland. That would be your ACTH secreting tumor. It could be an ectopic Cushing disease, which would be a tumor somewhere other than the pituitary gland that's still secreting adrenocorticotropic hormone. Or finally, you could have what's called adrenal Cushings, which means you've got a neoplasm in your adrenal gland, could be unilateral or bilateral, and that neoplasm is secreting way too much cortisol. So in all three of those conditions, there's something causing your body to push too much cortisol into the bloodstream, causing systemic symptoms, including hyperglycemia, poor skin growth. Skin manifestations are very common because, as we said, skin cells are not going to be able to divide properly whenever there's a lot of cortisol around. And weight gain secondary to the high blood sugar. You get insulin along with that, and so you get this truncal obesity. So where the SDL then goes next is giving us a synopsis of these different etiologies of Cushing syndrome, and starts off talking about exogenous steroid administration. Again, that's 99% of cases, by far the most common clinically. And glucocorticoids are going to go to the nucleus. They can cross lipid membranes because steroids are just big lipids, and so they're lipid soluble, so they translocate to the nucleus with a cofactor and bind onto DNA, and they will suppress the expression particularly of nuclear factor kappa beta. But if the patient's not on steroids and they have a very high blood cortisol, you understand that they've got this endogenous, within the body, hyperproduction of cortisol. And that could be due to high adrenocorticotropic hormone, telling the adrenals to make more cortisol, or it could be due to a tumor that's secreting cortisol autonomously. That means on its own. Anytime you hear autonomous, that word used in reference to any hormonal axis, what that means is that the producer tissue of a hormone, in this case cortisol, is making it without requiring any stimulation to make it. So autonomous means it's uncoupled essentially from the need for a stimulatory hormone, in this case adrenocorticotropic hormone. So the SDL then runs through the three locations of endogenous Cushing's, which would be your pituitary gland, your adrenal glands, or third, an ectopic tumor. Maybe you've got a small cell lung cancer, and that could possibly be putting adrenocorticotropic hormone into the bloodstream. Now remember, those are centrally located, small round blue cell tumors, stained with neuron-specific enolase, chromogranin A, that good stuff. You might also get an adrenocorticotropic secreting tumor in the pancreas, maybe in the thymus. So a few different organs of the body could just push this ACTH into the blood that's going to go to the adrenals and tell them to make cortisol. You might also have an ectopic CRH producing tumor. Remember, CRH is a hypothalamic hormone, and medullary thyroid carcinomas and pheochromocytomas possibly could push CRH into the blood, which is going to tell the pituitary make ACTH, which will then go to the adrenals and tell them make cortisol. And then finally, if you have an adrenal tumor, that's producing cortisol on its own without any need for adrenocorticotropic hormone or CRH. And there are a few variants of that that we will get into at the end of this SDL. So good graphic here on page 4, showing you the cortisol hormonal axis, the HPA, hypothalamic, pituitary, adrenal. And the big takeaway from this is that notice that cortisol feedback inhibits the pituitary gland as well as the hypothalamus. So that means that if you have high blood cortisol, then eventually you're going to stop making adrenocorticotropic hormone, and also CRH, because your body's going to recognize you've got a lot of cortisol. You don't need any more cortisol because you have it in excess. So the brain shuts off stimulation of the adrenals. Now, if you have a pituitary tumor, what that means is that this tumor is going to be making so much ACTH that cortisol is really not going to feedback inhibit it at all. So blood ACTH is going to be very high in the setting of a pituitary ACTH secreting tumor. With an adrenal cortisol secreting tumor, conversely, cortisol is going to be very high to the point where it totally suppresses pituitary production of adrenocorticotropic hormone. And so if you have an adrenal tumor that's making cortisol, ACTH is going to be low. So that's probably your first step in differentiating causes of endogenous hypercortisolism after you've excluded, remember, exogenous steroids. And then finally, the most rare cause of endogenous hypercortisolism is going to be this ectopic tumor, as we said, lungs, pancreas, maybe medullary thyroid carcinoma can make that CRH, and it's going to be making ACTH or CRH on its own. And so in this setting, ACTH would also be elevated, as would cortisol. And so because the hormone panel is similar to a pituitary ACTH secreting adenoma, you would have to do a further workup to determine the location of this primary cancer. Let's get into the effects of cortisol. So you have this HPA axis that we just took a look at, and steroids essentially mean that you're getting cortisol from the outside. Your body doesn't have to make them. And so steroids are going to suppress CRH and suppress ACTH. Now, CRH tells your pituitary to make adrenocorticotropic hormone, but alongside that, it will also make pro-opiomelanocortin. And ACTH is actually produced from pro-opiomelanocortin, as well as MSH, which is melanocyte-stimulating hormone, which is going to account for some symptoms of hyperpigmentation you could see in hypercortisolism. Cortisol is normally produced at around 5 to 7 a.m. in the morning, depending on your circadian rhythm. And cortisol is a glucocorticoid. Let's go back to that because it's going to raise your blood sugar. So after you've been sleeping all night, your blood sugar drops because you've been fasting for 6 or 8 or 10 or however many hours. And so cortisol being secreted at the end of a fast is your body's natural reaction to a constantly dropping blood sugar. So cortisol spikes it on back up for you. Now, cortisol, as we said, also has these proadrenergic effects. It's synergistic with epinephrine, and so cortisol gets you alert. It gets you a little bit vasoconstricted, gets your blood flowing. And that accounts for why you wake up in the morning, because you get a spike of cortisol and then you can't stay asleep when your heart starts racing a little bit faster, you know, and your blood sugar goes up. It's like you got to get out of bed. So that's what cortisol does. Cushing disease means that you have a pituitary cancer that's secreting adrenocorticotropic hormone. So blood cortisol will be high in these patients, as will ACTH. You'll see some cortisol metabolites in the urine. And what's important for you to know right now as a medical student is that this pituitary tumor is resistant to negative feedback inhibition by glucocorticoids, because it's always on, you know. And remember that we said up here, cortisol turns off the pituitary gland whenever you have enough cortisol. But in the case of the OMA, the tumor, you know, that ACTH stays up because you can't turn it off. And so that's the basis of our diagnostics. That's, again, the first step is seeing, can we suppress adrenocorticotropic hormone in this patient or not? If you can, it's probably this adrenal tumor. If you can't, it's pituitary or ectopic in origin. So that's where we're going with this from a diagnostic standpoint. Ectopic, again, that word just means paraneoplastic. That's kind of a synonym for that. That means you have a tumor that's making something that that tissue type that the tumor is derived from doesn't usually make. And so maybe your small cell lung carcinoma is making adrenocorticotropic hormone. That's what we mean when we say ectopic secretion. And these tumors are also not going to respond to steroid suppression. And when we say suppression, we're again referring to the concept that if somebody has a high adrenocorticotropic adrenocorticotropic hormone and you give them cortisol or dexamethasone or any other glucocorticoid, well, then that should feedback inhibit the production of ACTH from the pituitary. So if ACTH stays high, you know that there's a pituitary mass or there's somewhere else in the body, there's some other tumor making ACTH. And then the SDL talks about primary adrenocortical disease. That means it's a problem with the adrenal cortices themselves, not with anywhere else. And these are not going to respond to steroids either because adrenocorticotropic hormone is already low because you're making so much cortisol from the adrenals that you're already suppressing the pituitary part of your HPA axis. So that's the nitty gritty. Let's get into what these patients look like. Centripetal obesity, most common symptom. Why do you get fat? Because cortisol is gluconeogenic. So gluconeogenesis, remember, when you run out of blood glucose, your liver will make more using pyruvate as the main substrate and drawing from blood lactate and blood alanine in order to make pyruvate whenever it runs out of its own glycogen stores. So because you're making all this glucose and putting it into the blood, well, what happens next? Your pancreas sees that glucose and you get an insulin signal. So the insulin signal drives excess glucose into skeletal muscle and into fat. And the insulin going into adipose tissue causes this truncal obesity. Now, patients also have thin limbs, arms and legs. Why do they have thin limbs? Well, because if your gluconeogenic signal is always on, one of the prime substrates for making pyruvate in gluconeogenesis is alanine. And alanine is an amino acid. And as you know, skeletal muscle contains most of the protein in your body. And so whenever you need alanine to make pyruvate, you pull it from skeletal muscle. And so it puts your muscle into a catabolic state and you waste that muscle. Here's an example of adipose deposition around the jawline, around the cheeks. And here, as you can tell on the right, whenever you treat the primary cause of Cushing in this patient, it's excess cortisol. If you can fix the primary problem, then metabolically, they're going to go right back to normal. This is a very reversible disease. Here's a table with clinical features. Patients will typically have 3, 4, 5 of these. And in a question stem, indeed, they will give you 3 or 4 or 5 of these before they ask you the question and be able to recognize a couple things like, I mean, obesity and the moon face, you got that. The buffalo hump, you got that. That's easy. But also hypertension, remembering that cortisol has those pro-adrenergic effects. Hirsutism is a unique one, particularly in women. And osteoporosis, finally, is another big risk of hypercortisolism because it puts you into a catabolic state in which you're breaking down tissues, and bone is a tissue in your body that is going to be broken down when you are in systemic catabolism. So that's not good. Looking at the skin manifestations, you see these purple striae. They're characteristic purple striae all over the front of the abdomen, and you really can't miss it. And you know you got Cushing's. If you have this plus like moon hump, it's like automatic. So why do you get these purple striae? Well, what are striae? Well, they're skin stretch marks. That's the colloquial term for them. And just because you have stretch marks, good news, doesn't mean you have Cushing's. In fact, a lot of people have stretch marks. I've got some stretch marks because I used to be about 50 pounds heavier, and then I lost a lot of weight, and then the skin had to go somewhere. So first I lost weight, and then I had a lot of excess skin hanging around, and then the skin thins itself out over time and tightens up. And the way that skin tightens up is through apoptosis. So let's say that you weigh 250 pounds, but then you lose weight down to 250. And let's say that happens really fast. Well, your body, your fat mass is going to drop before your skin surface area drops. It's going to take a lot longer for that skin to catch up. So how does the skin catch up? As we said, apoptosis. And stretch marks actually represent planes of apoptosis. Your skin is going to commence a controlled cell death in these certain regions or zones. And those zones are reflected by stretch marks. So when you see a stretch mark, what you really see is skin growth or skin apoptosis. They're areas where skin is really responsive to change. So in the case of someone who's losing weight, the stretch marks mean that right along that stretch mark, that's where skin cells are dying one by one. The basal layer specifically, it's committing apoptosis because you have too much skin and you need to lose it. But then in the case of rapid skin growth, those stretch marks represent zones where skin is just proliferating. So those are the stretch marks. And in the case of Cushing syndrome, so if we know that the stretch mark is where skin is reabsorbed, well, we put that with what we know about hypercortisolism, and then it really makes sense. Cortisol puts you in a catabolic state. Plus, cortisol inhibits genes that tell cells to divide. So one and one together right there. Cells need to be in an anabolic state to divide. You know that and I know that. Cells can't really divide if they're in a catabolic state. Furthermore, cells really are unresponsive to the stress signals that are telling them to divide if you're suppressing those stress signals at the nuclear level through suppression of nuclear factor kappa beta. So you add those couple of things together and you understand that skin cells are not going to do anything if they're being suppressed with glucocorticoids. They're just going to sit there and then die off, which is also what's going to contribute to the acne, the facial acne you see in lots of patients. Because again, if your skin is not proliferating, well, then it just gets a little bit thinner and thinner and thinner. And so you're more prone to just pick up a topical infection. And what's acne? It's bacteria. So hyperpigmentation you might see, and it's because this pro-opiomelanocortin is the precursor for both adrenocorticotropic hormone and melanocyte stimulating hormone. So that's what we got on the right here. On the left, we've got easy bruisability, which is a function of the thin skin. And the thin skin is a function of it not being able to divide properly. And so why can't your skin divide properly? Well, number one, because you're in a catabolic state, you need to make proteins to divide. And then number two, because the signals that tell skin cells to divide are mediated through inflammation, and glucocorticoids are thoroughly anti-inflammatory. So two reasons there why your skin can't divide, and that's accounting for the easy bruisability and the purple striae. What other symptoms we got in Cushing? Well, you're going to see suppression of the GnRH axis, gonadotropin releasing hormone. And so that goes to follicle stimulating hormone and luteinizing hormone. And so female patients with Cushing might show menstrual irregularities, amenorrhea, oligomenorrhea, because you need FSH and LH in order to initiate that process. Something also particular to female patients, signs of androgen excess or masculinity. Remember, androgens go to testosterone, estrogens go to estrogen derivatives. So androgens are your dude hormones. And so if you've got androgen excess, as you would in Cushing syndrome, then you're going to experience a little bit deeper voice. Maybe the hirsutism is going to pop up there, and it also contributes to the acne along with the thinning of skin. So androgen excess might help you differentiate a pituitary Cushing syndrome from a renal, a primary adrenal Cushing syndrome, because if you've got renal Cushing, you're only making excess cortisol. But if you've got pituitary Cushing, you're making excess ACTH. So ACTH is going to upregulate all adrenal functions. Let me show you what I mean there. Here's a chart from First Aid. So ACTH makes more cortisol, but ACTH also upregulates androgen synthesis, and the primary hormone for that is dihydroxyepiandrosterone, I think is what it's called. So if you have too much ACTH, you're making too much androgens as well as too much cortisol. But if you've just got this adrenal tumor, maybe you're only making too much cortisol. Muscle wasting and weakness, again, the catabolic effects of glucocorticoids. You're making blood glucose. You're making blood glucose. You're making so much blood glucose that your liver just runs out of glycogen, okay? And so when the liver runs out of glycogen, where do you get the glucose from? Well, you break down fats, you throw fats to the liver, but you also break down skeletal muscle, and you throw lactate and alanine into the liver to make pyruvate. Bone loss, as we said, is attributable to the catabolic state. Glucose intolerance, again, you're going to have hyperglycemia because you never really turn off gluconeogenesis. Even in the fed state, you still got a little bit going on because of all this cortisol. Cardiovascular disease is going to be secondary to cortisol's upregulation of adrenergic activity. Adrenergic sensitivity is a better way to phrase that. And also because the liver is making glucose, the liver's in a gluconeogenic state. So the liver's ramped up and ready to work, you know. And so while the liver's working, what else does the liver do when it's active? Well, it synthesizes clotting factors and other acute response proteins. So you're going to be a little bit hypercoagulable too because you're gluconeogenic and your liver is excited. Insomnia is common because the daily progression of cortisol, we said it goes way up in the morning and then it just kind of drops through the rest of the day, and it reaches a trough at around midnight to 2 a.m. That's when your cortisol is at its lowest. And so if you've got too much cortisol, well, low cortisol is something that helps you go to sleep, because if cortisol is going to raise your blood pressure, you know, and raise your blood glucose, those are things that happen when you're awake and that keep you awake. So when cortisol goes away, it helps you sleep. So if you got too much cortisol, it might be hard to fall asleep. And finally, a little bit of a immunomodulatory effect. They do suppress immune functions, but I want you to get this straight. Just because glucocorticoids, so prednisone, dexamethasone, just because a patient's using topical whatever glucocorticoid does not mean that they are at an increased risk of infection for every bug in the book. So don't pick that as an answer choice, because I picked that as an answer choice on a practice question. I got it wrong because the real answer choice was thinning of skin, because that's a way more common effect. Almost everyone who's using steroids, especially topically, is going to have that thinning of skin. Why? Because it puts your skin cells into a catabolic state and you need to be anabolic to divide. And number two, it's anti-inflammatory, and the signal for cells to divide is mediated through inflammation and stress. And so if cells aren't responding to that stress signal, they're not dividing. So thinning of skin, by far, number one side effect of topical corticoids. So increased risk of infection due to immunosuppression, yes, but really those opportunistic infections are the most common, and those are going to be in our elderly patients and our patients who are possibly post-transplant, already have something predisposing them to infection besides glucocorticoid use. So you look at the lab panel for someone with Cushing's, you're really looking for cortisol and ACTH, but something that might help you make the diagnosis is an elevated blood glucose hyperglycemia, because again, you can't turn off gluconeogenesis. You might see a low serum potassium. Do you know why you would see that? Somebody tell me. Because of the insulin signal. So you're gluconeogenic, so you got a lot of glucose in the blood, so insulin naturally follows, drives potassium into cells. Finally, hypokalemic metabolic alkalosis. So we know you got low potassium, but then you also get a metabolic alkalosis. Your blood pH goes up. Why? Well, because cortisol has slight agonistic activity, partial agonist at the aldosterone receptor. So we know that aldosterone is going to cause a metabolic alkalosis, because aldosterone upregulates this proton ATPase in alpha intercalated cells, and it also upregulates ENaC, epithelial sodium channel. So when sodium comes out of the renal tubular lumen, potassium and protons have the chance to go out into the tubule. So if you don't have any ENaC activity, then you're going to have less proton export. No, I'm sorry. Let me take that back. Because glucocorticoids have weak aldosterone mimicking activity, you upregulate ENaC. Got it. And so because you're hypokalemic, because of the insulin signal, you have less potassium available to go out into the tubule. So that means that when the positive cation of sodium goes into the cell, what happens next? Well, there's less potassium to trade with it, so you trade a proton instead. So the proton goes into the tubule, and you know that whenever you put a proton in the renal lumen, you got to put a bicarb into the blood. So there's your alkalosis, weak aldosterone activity. And this is a good time to go ahead and go through these slides I've assembled. Here's cortisol again. Cortisol gets metabolized to cortisone. It gets a ketone put on it right there. And that is very similar in shape to aldosterone. Cortisone is what has aldosterone agonistic activity. So glucocorticoids, their immunosuppressive function is primarily by their inhibition of nuclear factor kappa beta, which is going to upregulate the transcription of inflammatory cytokines such as IL-1, IL-6, TNF-alpha. And here's a slide that I pulled from a paper in Nature talking about coronavirus. And this is a good reminder that this is how most viruses and bacteria work, is by increasing the upregulation of those inflammatory signals. So COVID is going to increase nuclear factor kappa beta expression at the genetic level and lead to increased IL-6, increased TNF-alpha. This is also what lipopolysaccharide on the outside of gram-negative bacteria does. So glucocorticoids suppress NF-κB activity, thereby blocking essentially the inflammatory effects or the effects of the pathogen on the immune system. Now, it doesn't get rid of the pathogen, but in some cases, that's not the end of the world, you know, because the pathogen's not what's killing people. What's really hurting people is the body's inflammatory immune response to the pathogen. So you can see that downstream from all those cytokines that get released, well, if you have too much, that's called cytokine storm, and that can throw somebody into sepsis. And so that's why we use glucocorticoids to block inflammation in some infections. Just another example of what glucocorticoids are doing at the cellular level. Here's an example of a tumor cell that is secreting pregnenolone, a glucocorticoid. And by doing so, it's turning off the immune system in the area so that that tumor cell can go silent, unrecognized, under the radar. So the effects of this pregnenolone being released into the interstitial fluid is going to be suppression of M2 macrophages, suppression of M1, really. It's going to shift it towards an M2 response. You're going to see dysfunctional cytotoxic T lymphocytes. You're going to see more of a Treg response, which is anti-inflammatory more so than pro-inflammatory. And it's also going to interrupt natural killer cell functioning. And you need those cytotoxic Ts and those NK cells, which are cell-mediated immunity, specifically to pop cancer cell through granzyme perforin-mediated cell killing. So steroids are going to inhibit that and essentially, again, mask inflammation, which is situationally good, situationally bad. Here's a patient with hypercortisolism. Notice the man boobs, lack of a better term. And I only say that because, I mean, you can tell this is a pretty skinny fit dude. And so the truncal adiposity is really reflective of his hypercortisolic state. And got a little bit skinny arms here, skipping arm day or something. Maybe that's not his fault. Maybe he does arms 3 times a week, but he's just got too much cortisol. So why would his arms be skinny? Well, because whenever you are making glucose in the liver from gluconeogenesis, you do so from pyruvate, and your preferred substrate for pyruvate is going to be the glucose that you chop off of glycogen and glycogenolysis. But when your liver runs out of glycogen, it needs to rely on things like alanine and lactate to make pyruvate. And both of those two substrates are found highly in muscle. Lactate's produced as a byproduct of anaerobic metabolism, and then alanine you just have in abundance because that's where alanine likes to go. You have a ton of alanine receptors in skeletal muscle, and so it's just sitting there all the time. So you move alanine into the bloodstream, same with lactate, and then the liver picks it up and sends it into gluconeogenesis, and so you're wasting protein and you're losing muscle mass. This is just a reminder of the effects of catabolism and anabolism on wound healing. And if you think this looks like a Julie Sue slide, it's because it is a Julie Sue slide. And catabolism, when you're in a really catabolic state, wounds can't heal. You know, you need to synthesize a ton of proteins, and you need to build in order to properly heal a wound. So I bring this up to mention to you the skin symptoms of Cushing's. We said that you've got these stretch marks because your skin is just dying. It's committing apoptosis, and it's unable to divide and grow, you know? And so skin is going to die in mass quantities along these certain topographical lines, these stretch marks. When you see one of these, what that means is that that's a zone of dermatologic apoptosis. And so why is it apoptotic? Because you are in a generally systemic catabolic state whenever you have cortisol excess. So that's going to be inhibiting the ability of your cells to proliferate, hence the stretch marks. Cortisol also inhibits collagen synthesis. I've got a couple studies here linked if you want to take a further look at that. Here's your buffalo hump. It's a fat pad, kind of posterior supraclavicularly, like the T1, T2, C7-ish area. And you shouldn't get fat there. You should get fat in a lot of other places before you get fat there. So if you see this, you think cortisolism. Here is kind of a collar of hyperpigmentation that's going to be due to melanocyte stimulating hormone. This patient's got acne, looks like an adolescent girl. And again, remember, cortisol is going to cause androgen excess, and a hyperandrogen state is associated with breaking out. And then also remember that if your skin is getting a little bit thinner, then that means that your skin is less resistant to colonization by bacteria. And so acne is a topical bacteria most of the time. And then we're right back at the metabolic alkalosis. Want to remind you that cortisone has weak aldosterone agonistic activity, and so it's going to upregulate that ENaC. But in light of the hypokalemia that's insulin mediated, you're going to be pushing protons into the renal filtrate, and so you're going to be pushing bicarb into the blood, and there's your alkalosis. So that's all the clinical symptoms of Cushing. Let's talk about how you diagnose it. And what I really want you to understand is the dexamethasone suppression test, because the rest of it's pretty simple. But understand that whenever we want to diagnose someone with high cortisol, we're going to give them cortisol essentially exogenously to see if their ACTH will go down in response to it. And so that's the first step on our diagnostic pathway. Now, to measure cortisol, you're not just going to take blood cortisol, you're going to take 24-hour urine cortisol, because it fluctuates so much throughout the course of the day that you really want to get an accurate reading. And remember, that's going to be made in the zona fasciculata, the middle layer of your adrenal cortex. So dexamethasone is a steroid, it's a glucocorticoid, it's a cortisol analog, and it should normally suppress cortisol production in normal subjects to a very low level by inhibiting adrenocorticotropic hormone. So you've got a low dose and a high dose dexamethasone suppression test. The low dose test is going to tell you whether or not the patient has Cushing's. And the high dose test is going to further narrow down what type of Cushing that patient has. So let's talk about the low dose dexamethasone suppression test. You give someone a low dose of dexamethasone, and when you check their ACTH should drop because of the HPA axis way back on page 4 of this SDL. You remember that cortisol feedback inhibits ACTH. So if dexamethasone is a cortisol analog, it'll make ACTH go down. But in a patient with Cushing syndrome, ACTH isn't going to go down. So a positive low-dose dexamethasone test tells you this patient has hypercortisolism due to Cushing disease, endogenous cortisol overproduction. And then what you'll do next is you will order a high-dose dexamethasone test, and it's like 10, 20 times the dosage of that first test. So this is going to tell you whether or not the patient's got pituitary Cushing's. Remember that we said you could have pituitary endogenous hypercortisolism, or it could be due to a primary adrenal problem, or thirdly, it could be due to an ectopic tumor somewhere else in the body, not on the HPA axis, that's secreting ACTH or CRH directly into the bloodstream. So you order a high-dose dexamethasone test, and if the patient has pituitary Cushings, they're making way too much ACTH. So a low dose of dexamethasone is not going to stop this pituitary ACTHoma from making ACTH, but a super high dose can. So you give them a really high dose, and then you see if they're still making ACTH. So you check the blood for ACTH. Now, if ACTH stays up in the blood after the high dose test, and cortisol likewise stays up in the blood after the high dose test, you know that the patient does not have pituitary Cushings, because a high dose of dexamethasone ought to be able to overcome the high amount of ACTH being secreted by a pituitary oma and thus suppress hypercortisolism in a patient with pituitary Cushings. So if your high-dose dexamethasone comes back and the patient still has a high ACTH and a high cortisol, you rule out pituitary Cushings and you say, I'm looking for an adrenal problem, or I'm looking for a tumor elsewhere in the body that's making this paraneoplastic ACTH. Now, after you get your 24-hour urine cortisol and you confirm your suspicions for Cushing, another good test to do right off the bat is serum adrenocorticotropic hormone first thing in the morning. Patients with primary adrenocortical Cushings, meaning that they have a tumor in their adrenal gland that is making cortisol autonomously. Remember, those adrenal tumors do not respond to ACTH. And in fact, ACTH is going to be low in these patients because cortisol feedback inhibits ACTH. So you take a blood ACTH first thing in the morning, and if the patient has an ACTH adrenal tumor or a cortisol producing adrenal tumor, they're going to have low blood ACTH versus the patient with a pituitary adenoma that's got ACTH through the roof, so that ACTH level is going to tell you, is this an adrenal tumor that I'm dealing with? So if it's not, then you get your high dose dexamethasone test to narrow it down between a pituitary ACTHoma and a lung or a pancreatic, any ectopic ACTH or CRHoma. So you get your suppression test. And remember, if the patient has a pituitary ACTHoma, with enough dexamethasone, you can shut that sucker down. You can turn the lights off on it. But if you've got an ectopic, let's say small cell lung cancer that's making ACTH, you can throw all the dexamethasone in the world at this patient, and that lung tumor is not going to stop making ACTH. So that's basically what this big chart here, this flow chart, is trying to tell you. You can also take a CRH stimulation test. You can give the patient CRH and see if they start making even more ACTH. Now that's going to be useful in diagnosing a pituitary Cushing syndrome because only the pituitary gland responds directly to CRH. So you would inject patient with CRH, and if it is a pituitary tumor, ACTH is going to go up, 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 up. But if it's an ectopic in the lungs or somewhere else, ACTHoma, ACTH is going to stay exactly the same just about. You want to get an MRI, you are going to get an MRI just to be doubly sure, in this day and age. MRIs do sometimes miss pituitary tumors though. And a gold standard for diagnosing pituitary ACTHoma is going to be inferior petrosal venous sinus cath. You're going to put a needle up into this venous plexus. Remember, this is going to drain to the back of the skull and then out the vertebral veins. And you've got your basilar plexus here and your circular venous plexus around the cavernous sinus. Remember, the pituitary sits right in the middle of the sphenoid bone there in the sella turcica, and the plexus of circulation around it, venous circulation, we're going to call that the cavernous sinus. And so within that space, you also have cranial nerves 3, 4, 5, 1, 5, 2, and 6 running through there. So that's a sensitive location, really bad place to get a clot. But we're going to stick a catheter up in there to monitor blood levels of adrenocorticotropic hormone after we give a patient CRH. And remember, we just said that if a patient has a pituitary ACTHoma, you give them CRH and ACTH is just going to go straight up. But if they have an adrenal problem or a ectopic tumor secreting ACTH, then the rise in ACTH when you administer CRH, if the patient doesn't have a pituitary problem, is going to be negligible. You know, you'll see it go up, but it won't be like, zoom. So if they have a pituitary ACTHoma, you give them CRH, it goes through the roof. So now we talk about the pathology of these different tumors, what they look like, where they are. First, there's the corticotroph adenoma, the ACTHoma. They are characteristically microadenomas, less than 10 mil in diameter, which is why we're getting an MRI and not a CAT scan, by the way. I think I said MRIs miss it, but CAT scans miss them a lot more, you know. They do not enlarge the sella, so what symptom will you not see? Bitemporal hemianopsia. On histology, ACTHomas of the pituitary are going to be basophilic, and elevated ACTH leads to adrenocortical hyperplasia. Corticotropic hormone, well, the cortexes are growing, tropic growth, and so of course you're going to see bilateral adrenal hyperplasia. So if you saw unilateral, you'd say, oh, that's probably a primary unilateral adrenal tumor. Couple of different adrenocortical neoplasms you can get, benign or malignant essentially. Most of them are benign. They tend to have a foamy cytoplasm, similarly to what normal zona fasciculata looks like. Foamy because they're making lots of lipids. All these hormones are lipids, and the lipids will wash out with stain. The adrenocortical adenoma is a benign tumor. That just because it's benign doesn't mean it can't secrete anything. If it's benign, that means it's non-invasive. Versus malignant, which is invasive. But both of these can make cortisol or aldosterone. And again, they're going to be secreting these hormones independently from ACTH stimulation, or in the case of aldosterone, from renin-angiotensin activation. Peak incidence, 25 to 40 years of age. We're thinking young to mid-adults here. Now, adrenocortical carcinoma is a malignant aggressive cancer. And remember, these cells, if you do have a primary adrenal tumor, will be popping out of the zona glomerulosa or the zona fasciculata, which make aldosterone and cortisol respectively. P53 mutations in these aggressive cancers, that makes sense. Similar age distribution, not much else going on. They will make it evident with words or with histology that the cancer is benign versus malignant. And then to wrap up this SDL, infrequent causes of Cushing syndrome, we've got primary bilateral macronodular adrenal hyperplasia. And we've also got, here it is, primary pigmented nodular adrenocortical disease. So I'm gonna let you guys tackle these on your own, really. I've kind of summarized them here for you. In this primary bilateral adrenal hyperplasia, you've got really big adrenal glands, and again, it's bilateral. You see macronodular versus micronodular hyperplasia. So this is a callback to cirrhosis almost. You've dealt with these concepts before. And the genes are particularly of importance. In PBMAH, you see MIN1, multiple endocrine neoplasia 1. You see the APC gene mutated. We've seen that with FAP, hereditary colon cancer, and also GNAS1. I like this one a lot. That's a G protein alpha subunit 1. And where have we seen that gene before? We've seen it in McCune-Albright syndrome, which is polyostotic fibrous hyperplasia. And so these patients will come in and they'll probably have some bone growth, and they'll have unilateral cafe au lait spots, and that's a really particular finding. They're also going to have some messed up endocrine axes. So you can see something like young children, young teenagers with just premature puberty, and maybe messed up blood cortisol levels, stuff like that. Now, the primary pigmented nodular adrenocortical disease, you've got small atrophied adrenal glands that are grossly pigmented on biopsy. A couple genes, you've got the PRKAR1A and the PDE11A. And this last one, primary pigmented, is also popping up as part of this thing called Carney complex, which I won't dive too deep into that either, but it's something you ought to recognize just in case you see it again. So both these tumors, or rather disorders, both of these two disorders would give you excess cortisol, hypercortisolemia, due to primary production of cortisol by the kidneys. And so you do your ACTH tests, and it's the sort of stuff you will think through really quickly when you're taking a test, getting a question on it. If you can't suppress ACTH with that low dose test, well, then what that means is it's probably a pituitary problem. But if you can suppress ACTH with that first test, as we set up here in the diagnostic section, then it's probably an adrenal problem. So then you do the low dose dexamethasone, ACTH is normal, patients got, or I'm sorry, let me think about this. You do the low dose dexamethasone, ACTH is normal, patient's got Cushing's. ACTH should go down if patient doesn't. Then you do the high dose dexamethasone, ACTH stays up. Patient's got one of those adrenal pathologies at the bottom of this SDL. And then finally, you do urine ACTH first thing in the morning. It's low. Then you're thinking the primary adrenal tumors at the bottom of this SDL. So that's a recap of the diagnostics. Thanks very much.